We'll get all settled in a second. We're all on a timer with the live surgery, so we're gonna go up and mark the first patient. Everyone's done? Good.
Mhm.
We'll mark the first patient, then we'll get settled and start. Okay, so if you wanna bring your pads and take notes of anything, we'll head upstairs. Under the eye, lateral orbit, that's very nice. One of the most popular areas, of course, are cheeks, nasolabial, and labial mental, and here. Sometimes people, as you get older, the bone from the jawline, the mandible gets smaller, it absorbs over time, and adding an angle to the jawline looks good, and also building up the chin area. So every patient's different, that's why you have to look, mix and match, customize. So on the next patient, we'll think about things like that. So the autologous fat transfer has been our missing piece. It's got a lot of great advantages. One is you've got these patients who want volume, but they're getting sick of coming back for fillers, or they just have large areas to do. Like the last 3 or 4 patients we've done in the trainings, we added up the dollar amount if we were doing fillers, and we had between $30,000 and $55,000 of fillers, of same volume of putting in. So it's just not feasible if they need a large area to do. Or they have liposuction they want to do, they've got excess fat, and if it's those patients, you may say, why do you want to waste that golden fat? And let's see, put it to good use. And some just want to use their own tissue, is what you said, and make it more natural. Facial rejuvenation today can be a combination therapy, multimodality, but the strong push in the last couple of years has been toward minimally invasive. So we've been doing fat transfer for over 20 years. We've used every technique there is. The problems were it's a time-consuming extraction process. There's damage to the cells during harvesting because it used much higher vacuum pressures. It was a multitude of steps and became very cumbersome. You're going to see how easy this is to use. And there were very unpredictable success rates. The reason it was unpredictable is because depending on which study, you lost anywhere between 30 or 70% of the fat or more. And when people are paying a lot of money for these things, how happy are they going to be if they don't have 70% of what they paid for? It's like you bought a 10-room house, and after a couple of years, you're down to 3 rooms. How are you going to feel? So we needed to advance that, because some patients were very happy, but some were very unhappy in what we do in aesthetics, especially today where they can go review you and all that. You don't want this group getting very unhappy. And then some patients kept the fat they didn't want, so it was all over the map. The evolution of fat transfer, even going back to just the harvesting of the fat with liposuction, which started in the 1970s, we had dry liposuction where they just went in with a cannula and pulled fat out in big clumps, and half of that was blood, and they needed transfusions, and the skin was all irregular. That was not a pretty sight until Dr. Klein and Dr. Hunstad created the tumescent liposuction technique, where epinephrine and lidocaine and the tumescent fluid were all added to this. That made it a much safer procedure and better results. Liposculpture in the 1990s, then it wasn't just bulk removing fat, but actually sculpting the body and doing it that way. And then the fat transfer choices in the 2000s and forward, starting with Dr. Coleman, introduced this revolumization, again with the different techniques. So the historical challenges of fat transfer was the liposuction, all the systems we had were designed to remove fat, not save the fat. The additional steps to process it with centrifuges and all this was damaging it, not really preserving it. And the quality of the fat then was poor, and that's what gave all these unpredictable results. So one of the biggest things that was harming the cells was the high vacuum pressures of regular liposuction, and that just caused disruption of the cell walls and the disruption of up to 90% of the fat cells. So limitations of the fat processes were also from the centrifuging. There was sedimentation. The centrifuge, one of the good things was it separated out all the excess fluids and the oils, but one of the bad things is, the really good part is this little white layer that has all the growth factors and all the really good things in it, and that was being removed as well. You'll see in the BeautiFill system it's being all the junk, the fluid and the oils are being pulled out through the mesh into the other container, but we're still saving all the good things. Let me just see if that was them. Okay, so we're going to stop there. Now, just under the dermis was my last step. And this is not the longest cannula in the set, is it? Look how long.
There's another infiltration cannula.
Right? And especially when I'm trying to just stay within the tattoo, I can't go further. Okay, let that work. Let's get the last area turned this way. Oh, number 11. Okay, last area here. Yes. So it wasn't packed with the set?
It just somehow got separated.
Alright. Make sure that stays on the set. I just need to go a little longer here. Right. And again, going deep to superficial. I wouldn't feel any of that. is opposite, superficial first, deep second.
Your right hand's always feeling.
Feeling. This is more important than this.
Okay.
This is the Judgment Man. And it's feeling for smoothness, it's feeling for depth. Okay. That's 60. Bit of extraction and processing the fat. It's suitable for large or small cases. And as you can see, it optimizes the time to process and the quality of the fat you saw coming out. So years ago, people drove those, and I used these. Every single one of those machines I had. I just found this nice company that buys up all your old stuff, and they came in on Thursday, and cleared them all out for me. But yeah, you as you go long enough in this space, you build up things. But that's what we used to have to use all those different things, and now we're driving things that look like that, and that one system does all of this. And you don't need all the other, and all the tools come with it. And they're both the white color. So, to your point, patient selection, right? Who's the right candidate? So they should be in excellent health. If we're doing, like, if I'm doing people in the office under local, they need to be in excellent health. That doesn't mean I'm seeing the people I saw this week with kidney transplants and all that, we could still do them, but not in the office. You get full medical clearance. There's a way to do anybody unless it's a disaster, they're done in the hospital, etc. But in general, for most of the cases you're gonna do, excellent health. They look better if BMI is less than 30, that their weight is stable, and they have localized subcutaneous deposits, like this woman's leg. Those areas I marked in topography were out of proportion of the rest of the view there. And a lot of these people try to diet exercise and it doesn't go away. They should have normal skin tone or elasticity, otherwise you're going to do something to tighten it. She has horrible skin and cellulite, but she knows that, and she knows this is not going to make that go away. 18 to 40, ideal, but if you're doing facial rejuvenation, those people are older. Who shouldn't we do? People have weight gains up and down, excessively loose skin that'll look worse by taking this fat out, or if they have unrealistic expectations, listen to words like, I want to look perfect, I want immediate results, I'm doing this because I want to lose weight. Well, you're not going to lose any weight from what I'm doing. Or they're emotionally or physically, psychologically unstable. I mean, you've been around long enough that you can hear the way they talk. It just doesn't sound right. Sometimes if I'm unsure, we could get a site clearance and think maybe okay, but if that's not your field, then get your experts to help you. Or if they have coexisting eating disorders or body dysmorphia disorder. Medical contraindications are morbid obesity, pregnancy, cardiovascular disease, coagulation, hepatitis, immunosuppression, cancer, malignant hyperthermia. For the pre-op, you want to get your medical surgical history, looking for hepatitis, HIV, chemotherapy, anything that will find those exclusions in there. Or risk factors for thromboembolism, because when you're doing lipos, the risk goes up, and you want to watch out for that. Yes?
How, in the world we live in now, patient had COVID, they did fine, weren't hospitalized, never had a DVT, they simply tell you they had COVID. Are you waiting a particular time after that?
No. unless I thought the COVID did something that it's gonna tick off one of these things. If they have a negative COVID and they get, and if, put it this way, not here, but we do the same rules, if whatever they have going on, the hospital won't let them in the door, then I'm not gonna let them in the door. Cause the rules change every week. You gotta get your informed consents, do whatever your protocol is, EKGs over 50, but on our rule, I don't care if you're 18 years old, you get medical clearance. Photographs with good lighting, because you wanna show before and afters. And I didn't wanna say it in front of the patients upstairs, the reason we do medical clearance is because on the young patients is because a plastic surgery practice on the street behind us did a rhinoplasty on an 18-year-old girl who was in May, graduating from high school in June. Both her parents were physicians at the hospital. They did the surgery, something wasn't right. She went to the ER, so whatever, they sent her home. She went back to the ER the next day and died.
I knew you were gonna say that.
Her sodium was 120, her normal sodium was 124, hyponatremia, no one knew it, and their protocol was, H&H and a UA.
Oh, wow.
So I don't wanna be the one killing both parents, daughter graduating who's 18 years old.
Yeah.
So since then, we've found all these things. So do what you want. You're medical doctors, so you probably know what I don't know, but we clear everybody.
You check
'Cause
thyroid and
Because
stuff.
the last thing you want for an aesthetic procedure is to have that, or any other complication.
Yeah, yeah.
So you'll watch, I'm like very particular over everything, 'cause it's aesthetics. You already look okay, we're trying to make you look better.
Yeah.
And if we don't, or whatever, this little mark wasn't there before, you did it.
But, I mean, unless you get a BMP or a CMP, you wouldn't know about that sodium.
Well, her sodium might have showed up low. And you would have said, why is it low?
Yeah.
So if our medical doctors see anything that's abnormal, they'll either take care of it, or they go, you need the cardiologist, you need the hematologist. So, and that's why, those patients we're doing at the hospital, because in the hospital building, all their offices are all there. Sorry. So, no, we get clearance on everything. So that's why. I have a reason for everything I do. Okay, pre-op, they get first generation cephalosporin, they get antibiotics starting the night before, or doxycycline for 7 to 10 days. So this is not a dirty cake, but I'm working in areas that are not the cleanest, and again, with aesthetic cases, anything that goes wrong is a problem. If you have an infection, if this fat gets infected, it will not look right later. So yes, antibiotics. Bruising, it'll go away on its own. They can take vitamin K twice a day, arnica tablets. And if they're very anxious, you can add something like that to keep them calm. The direct tumescent technique, so now we're talking about putting the fluid in. So the advantages of this fluid is that it's direct percutaneous interstitial fluid. We'll show you the formula in a second. You have profound subcutaneous local anesthesia. There are no systemic anesthesia needed. Profound hemostasis. You saw we didn't see any blood. It hydraulically lifts the tissue up, so you have a bigger space to work in, and there's no third spacing or needing for IV fluid. Remember we said in the 1970s they did dry lipo, and in the dry technique, look at that. Everything's wrong with it. You needed general anesthesia. excessive bleeding, needed transfusions, prolonged recovery time, and contour irregularities all over the place. With what's called the super wet techniques, we add the formula, we need less fluid injected, and just everything down the board, down the line changed by adding the tumescent fluid. Further on the antibiotics, so again, do it in everybody. If they're allergic, we use clindamycin. We give specifically 500 milligrams PO the night before. Then the morning of, they should eat something, because otherwise the antibiotics, whatever they're getting is going to irritate them. They'll get nauseous, and then they'll continue 500 milligrams PO twice a day for 5 days after. Here, this is in your book, so you don't have to write it down, but there's the formula of what we're mixing, and that's changed everything. So those bags we're using has all of this. Some areas to note when you're putting in your fluid that are harder or more sensitive are the upper abdomen against the costal margin. There's more nerves there. Around the umbilicus, there's more nerves there. The back and the breast are more fibrous, so it's a little harder for that to infiltrate in. More lax areas are the upper inner thigh, and may take a little more volume to, did you see when I was filling it up, it's kind of firm? Those looser areas may take more fluid to get tight like that.
Okay.
The fluid infusion, you can go deep to superficial or superficial to deep. So I was starting, for the fluid, not the suction, I was starting deep, and then I was fanning and coming up, because the nerves live up on the surface, so if you hit those first, it's going to be more painful, so it's coming up and helping the nerves. And you're feeling, my other hand's doing all the work in the whole case. It's feeling the fluid coming up. If I started on the surface, it would be all hard and I wouldn't feel anything. It's the opposite when you suction the fat. You're feeling it coming down. Coming up, coming down, this hand's feeling everything. The pump's on the side of the machine, you saw that. You need to know the pharmacokinetics of lidocaine, because the worst thing can happen is lidocaine toxicity, so you need to understand that and your limits. Hopefully, if you're doing this under local anesthesia, we're not doing cases big enough that we would get to these limits. Where's Tim?
Yeah,
He went away.
take a phone call.
But one of the doctors that trained a few months ago texted me and said, hey, I just did, 4,000 or 5,000 cc's in my office, and he was very proud of that under local, and that's not what we said.
Oh,
So you may need to know who that is.
yeah, I'll talk to Tim about that.
Don't get so confident. Don't be that confident. If I said that amount, we will do 4,000 or 5,000 cc's. Our society has in writing over 5,000. The complications goes up like that, and you would never stand up in court when they pull that out. And I also said if I'm doing that amount, I'm in the hospital with an anesthesiologist and staying overnight monitoring all night. So I did not say that, but this person's doing it in their office. So, Brandon, you're in charge of
Yes.
remembering that,
I am
because
taking notes.
I forget everything.
Me
I
too.
did remember that. I think that message was within the last week. So don't do that. Why? Because we have dosages. With liposuction, if you're safe. If you do 45 milligrams per kilogram, you're pretty safe. If you do 55, you're really safe without lipo 20. If you take a board exam or something, you see this on the TED, and don't go in excess of 7 milligrams per kilogram. Well, that's based on a letter from 1948, before there was any liposuction. That's not correct. It's the 45 number. And you can see, if we do 45, and here's Dr. Klein's paper, you can read that paper if you want to do all that. But what you need to recognize is, as that lidocaine level comes up, it reaches peak plasma levels at 12 to 14 hours. The first things you'll notice are perioral numbness, lightheadedness, drowsiness, visual, auditory disturbances, muscle fasciculations, but as you start getting concentrations over 10, unconsciousness, seizures, coma, respiratory arrest, cardiovascular depression. So that's why you're not going over. So find your patient's weight, multiply 45 milligrams per kilogram, give them the right dose.
Should that be 45 milligrams per kilogram?
Yes,
Oh, go back. It looked like it was, okay, yeah,
milligram
per kilogram?
per kilogram.
Okay,
If we go back further,
okay, yeah.
very good. Milligrams per milligram. So what are the indications? There's cosmetic indications, there are non-cosmetic indications. And it's subcutaneous fat, it's not the fat between the liver and the stomach and the intestines, that don't go poking your cannula inside the abdomen, because it'll be hard to stop that spleen from bleeding.
Right.
Lipomas, localized lipodystrophies like buffalo humps from steroids, endocrine disorders, reconstructive things. So there's a lot of things you can use liposuction, and that's other than cosmetic. So back to patient selection. If someone has localized fat, yes. The guy on the left, if you pinch him, he has no fat here, but he's got this big belly. He does have fat, it's all inside his abdomen. It's all intra-abdominal fat. He has metabolic syndrome. He's not treated by liposuction. That's a medical treatment. Look at his other things, what he's eating, drinking, but treat that way. But you have to pinch the fat to know you can get it out. Nothing's more important than patient selection. As long as you get that right, then do the correct procedure. If you get that wrong, nothing will help you. Set realistic expectations, post-op, pre-op, discuss the risks, benefits, alternatives, assess mental, physical capacity, and all those contraindications we listed, exclude those patients. Again, to repeat, ideal liposuction patient, excellent health, BMI, etc.
If you, for some reason, the power went out and you had all your fat harvested, how long is that good before it needs to be used?
Say that again, if you're
We get all the harvest done, we're ready to put it where we want to go, and the power goes out. How long is that still good
Put
to
it on
switch?
ice, we can probably wait about 6 hours.
Okay.
If that happened to us, it takes about 10 seconds for the generators to switch over. All the red plugs in that room have a natural gas-fired generator, so it will never run out of fuel, so we can keep going to do the case,
Okay.
because we don't want to be in that situation.
Can the BMI be less than 35? That was something that we, oh,
It could be high. I mean,
well, but you want somebody
what
who-
they're trying to say with that is, if you get these big fat patients,
Yeah,
you
can't
can
do it.
take all the fat, they're still not gonna look
Yeah,
good.
yeah.
If their BMI is 30 or less and they have localized fat, they're gonna look very, very good.
Mm-hmm.
In the bigger patients, can you do them? Say that there's big body, but they need it in their face. All right, that's fine.
Yeah.
But from the liposuction standpoint,
It's
you're not
not
gonna
gonna do
really
much.
change them. They're not gonna look better.
Okay.
and the contraindications, the exclusions know that, and the prep. Okay. So lidocaine is metabolized through the liver, so if they have abnormal LFTs or any drugs, all those antidepressants, antifungals, anything that interferes with that, you want to recognize. And I'm not gonna say all this because it's in your book, but, whoops. That's not it. But look at all those things that interfere with, if they're on those drugs. So the cannulas, the set comes with a bunch of different cannulas, and they're all different types of cannulas, spatula, triport, but these are especially designed with the orifice, so the laser is in the center, and the laser's making this concentric ring, and it's tuned to water, so there's fibrous tissue that holds the fat cells apart as 90% water, so it's breaking up that fibrous tissue so the fat cells loosen and come out better, and you don't get all the garbage. That's how the BeautiFill system is designed. Smaller cannulas, larger cannulas. So the advantages of small cannulas are there's decreased pain, it's more uniform results, less risk of over-suctioning. When you start, you may want to use the smaller cannulas. If they're a big fat patient, it's not gonna matter, but like the lady I did first, if I overdid it in her, we got a big problem. So maybe when you start with the smaller cannulas to get your get your feet wet doing it with smaller cannulas. Okay, 1 second. The larger cannulas will remove fat faster, they have a longer reach, but again, the biggest thing you can go wrong with cannula size is overdoing it. If this thing's moving a lot of fat out and you create a divot, that's a bad problem. The entry sites we make with a number 11 blade, a couple millimeters, you can use a punch, and watch if the size of the hole's too small, your cannula will rub on it and create rubbing, so make it big enough so there's no abrasion. In darker skinned patients, you may get, if you're doing a lot of trauma, inflammation, post-inflammatory hyperpigmentation, and try to hide them in skin folds, stretch marks, tattoo areas, anything. 2 minutes. All right, so let's see. And then the liposuction technique, it's like in the abdomen, go right, left, or through the umbilicus, use multiple entries so you're crisscrossing. How you doing? This is Dr. Travados, he's one of the trainers also for BeautiFill. We've got him from all over here. And then just remember I did the opposite when I did the liposuction. With the fluid, we went down, up. With the suction, I went top, down. We're gonna stop there, because we were talking about something. Okay, and now I'm gonna put this on there. Thank you. Oh, that's fine. Clamp it so you don't lose it. Now, we're going to do this whole part with a 10 cc syringe. We'll take as much as we can get. Hold upright, leave the other 10 here. Okay, so hold up so they can see. So what? So same thing, pull your fat out. Like so. And I'm going to take another, where's your caps? Where's your caps? Caps, please. We gotta put it upside down. Where's the caps? Let's take the other 10. Okay, so actually, let me put some in here. Here, we'll just take it out. I need an empty 10.
You need me to grab
I
another
have a
one?
10.
Okay.
You need?
No, just do that. Okay, so I put a lot of fluid in there, so I want to get some of that fluid out. Where am I putting it? Here. So to process, what you do is you take two 10cc syringes, and that's where these guys go back and forth. And to process, so take a look at what that clumpy fat looks like.
Yeah,
See that?
yeah.
So you go back and forth 10 times. 3, 4, 5, 6, 7, 8, 9, 10. This is reduced to 2.4. Look at how that looks.
Yeah, smooth.
Nice, right? Now, I'm just going to show you what she's going to keep doing. Then I'm going to take the 1.4. Where's the 1.4? And we're going to do the same thing. If you use too large a syringe, you have to strain too much, so 10 is ideal for processing. Look at how that looks, the 2.4. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. You might feel it a little harder on the first few, but then it gets very easy, like that. Now look at how that looks. And then let's process for the lips and the eyes. So I'm going to go ahead and calling them, wait, what's happening?
You can't do anything without a computer.
So we just got rid of it. And next, we had next tech before, so we don't have to change them by a new system. But when it went to the cloud-based, it became much less expensive than same thing, 10cc. Pull out another 10 and we'll compare it to the native, what's coming out. 5, 6. It gets harder with each smaller one. 8. So just hold that up for a second. 9, 10. Okay, so look here. Look at what we pulled out. And look at what I got.
Okay.
So the processing looks very nicely.